Welcome, everybody. Thank you for attending this meeting. I'll introduce myself. I'm Alan Schindel. I'm a professor of urology at UCSF and was on the ejaculation guidelines panel. My colleague Stan Althoff is here. I'll let him introduce himself.
Oh, thank you, Alan. I was also on the ejaculation guidelines committee with Alan and a group of other prominent people. And I'm a professor emeritus at Case West Reserve Medical School in Cleveland, but I live these days in West Palm Beach, Florida.
That sounds really nice to me, as we were discussing. So anyway, thank you again for attending. Why don't we just go ahead and get started on this presentation? So these are our disclosures. Stan has a few more than I do, but I think none of these are going to influence our presentation of these data, nor unduly influence our practice in terms of how we care for patients. I do want to disclose that we are going to be speaking some about pharmacotherapy for premature ejaculation and delayed ejaculation, and none of these are FDA approved. So everything we're talking about is technically off-label, even though it does have a very strong and robust evidence basis. So I think you can feel good prescribing these things, but it is important in documentation and in discussions with patients that you talk about how these are all technically FDA not approved. So our hope is at the end of the session, you will have a sense of the evidence-based data to support how to diagnose, how to evaluate, and how to treat men with disorders of the timing of ejaculation. Primarily, we'll talk about premature ejaculation because that's where most of the data are, but we'll talk a little bit about delayed ejaculation at the end. And Stan is here, and we're fortunate for that because he's truly a world expert on this topic, and he can talk to us a lot about the mental health approach to managing these disorders, which is obviously critical to success in all cases.
Just a quick question here. I don't see the slides advancing. I see it saying enable editing.
Okay.
I see.
Let me put those back here. We'll scroll through them again.
Now.
Yeah. Okay. 2.5 years in, we're still struggling with Zoom clearly. So let me start again. I'll go back and just, yeah, there we go. All right, perfect. So I'll just go backwards here briefly just to show you these are our disclosures. This is the thing I said earlier. These are the objectives. And here we have our introduction slide. So sexual climax is a distinct entity. It is associated with two separate phenomena. That is to say orgasm, which is the sense of pleasure and excitement and intimacy and emotional closeness that goes along with sexual climax. And there's ejaculation, which is the expulsion of semen from the urethra. Most men do experience a sensation of what we call ejaculatory inevitability. So a sense that, okay, climax is coming, nothing I can do to prevent it now. And this is not entirely understood how this is modulated, but it's a complex set of inputs from a number of different sources, all of which are integrated in the central nervous system and have basically a different threshold point at which a man will experience sexual climax. I was never a very good neurologist, which is part of why I'm in urology instead, but I do want to articulate what I was saying earlier, how central nervous system mechanisms are very important in this. And a general principle you can apply to your clinical care of patients is that serotonin generally opposes ejaculation responses. So drugs that enhance serotonin activity, such as SSRIs, Prozac, being the classic example of that, will tend to inhibit ejaculation or make it actually impossible in some cases. Dopamine has kind of the opposite role. So we'll sometimes take advantage of these different properties of different drugs that modulate these two main neurotransmitters to try to stimulate or inhibit ejaculation responses. And we'll talk more about that later on in this presentation. In the periphery, there are two distinct phases to the ejaculation reflex, that is emission, which is under control of the sympathetic nervous system and has to do with deposition of sperm and seminal fluid from the prostate and seminal vesicles in the posterior urethra. It's also very important during this phase of the ejaculation cycle that the bladder neck is closed, once again, under sympathetic tone. So sympathetic tone causes the bladder neck to close, the internal urethral sphincter, and that prevents retrograde ejaculation from occurring so that semen goes the antegrade fashion out through the head of the penis. Emission is followed immediately by ejection, which is under the control of the somatic nervous system. And this has to do with contraction of the ischio-cavernous and bulbospongiosus muscles, which forcefully contract and expel semen through the head of the penis. This is under control of the S2 through S4 somatic nerve route through the pudendal nerve. Orgasm is something that, again, a little bit hard to define, but the Webster's definition is right here. And you can understand that this is a distinct phenomenon. This occurs in the brain and in the spinal cord. it can occur in the absence of ejaculation. For many men, the experience is simultaneous and sort of synonymous. It is possible to have one without the other. There are some data suggesting that the force and volume of ejaculate is correlated positively with a man's subjective pleasure with orgasm, which has something to do with the fact, at least hypothetically, with the notion that many men equate ejaculation volume and ejaculation force with how much pleasure they have. It's a complicated topic, not entirely well understood exactly why that's the case, and some of it's probably more psychosomatic than real, but there definitely is an importance to ejaculation for many men that transcends its role in reproduction and transcends the association with orgasm. Ejaculation itself is part of the experience for many men, and loss of this or disruptions of this can be very distressing. So disorders of ejaculation, there are many of them. They can cause substantial bother, and they're not as well understood. You know, we know a lot about erections. We can talk about those all day and have all sorts of treatments for them. But really, we don't have as many for ejaculation issues. We don't understand it quite as well, but we still have evidence-based therapies we can turn to, which we'll talk about in the rest of this presentation. One of my pet peeves, and something that you will encounter if you review these literatures, is this numerous citation. All the time, these articles start with a citation: premature ejaculation is the most common male sexual dysfunction. This is based largely on studies that have been done over the decades, usually relying on single item patient-reported measures, which can legitimately be answered by a man who says, well, you know what, 6 months ago, I came before I wanted to, so yeah, I'll say yes to this question. So a lot of men will occasionally ejaculate before they really want to, but that in and of itself does not make a diagnosis of premature ejaculation. My friend Stan, basically has some interesting data on this, and the ISSM guidelines on PE that we came up with about 6 or 7 years ago estimated a much more realistic prevalence of about 5% of men who have the constellation of symptoms that we define as diagnostic for clinically relevant premature ejaculation, and I'll define those for you in a moment. But really, as common as it is, and as important as it is, it's certainly not something you want to dismiss or say doesn't exist, but it is not 30% prevalence in terms of clinically relevant PE that mandates a medical or a dedicated sex therapy approach to managing. Some of the controversy about this has to do with how you define it. And again, there's a big misconception. A lot of patients have erroneous notions about, what is normal? What does a normal sexual encounter look like in terms of duration? And we have here data from the late and lamented Dr. Marcel Waldinger, who did as much work on this as anyone in the world, and really contributed so much to our knowledge about this. These are normative data from Western countries looking at ejaculation latency times using a stopwatch study. And you'll see that the clustering of these ejaculation latency times from the moment of penetration to the moment of ejaculation puts the median at about 5 or 6 minutes. So the bottom 2.5 percentile of Western country ejaculation latency times are 1 minute or less. There is a lot of variability, though, in terms of not just the latency time, but how much bother people have about it and whether or not they feel a sense of control. This was another study from around that same time, and I love it because it illustrates some of the limitations of prior definitions of premature ejaculation. You see here on the x-axis, the IELT, the intravaginal ejaculation latency time in minutes. And you'll see, as you would expect, the light gray bars, men with PE, as diagnosed by the DSM-4 text revision definition of PE, clustered at the lower end of the spectrum, as you would expect. But if you look at the entirety of this graph, you'll see that there are light gray boxes for men who have latency times of 11 minutes, 14 minutes, even 20 minutes. So these are men who met the criteria for PE based on DSM-4, but had latency times that were well above the median. 20-minute ejaculation, I think most people would agree, that doesn't really seem premature for most people. At the same time, you see that there are men in the black boxes who had latency times of 0, 1, or 2 minutes who didn't really meet criteria because they simply weren't bothered by it or their partner wasn't bothered by it. So the take-home message of all of this is that really there has to be a constellation of symptoms that together make a clinically relevant diagnosis. So at the AUA, Stan and I and our colleagues really put it together as such. The lifelong premature ejaculation diagnosis consists of lifelong consistently poor ejaculation control, bother, and latency time of about 2 minutes or less. And the acquired definition is similar in that you still have the issues of bother and lack of control. There aren't as many data, objective quantitative data, on what constitutes acquired PE in the time-based criterion. So we define that as either a 50% reduction or a latency time on the order of 2 to 3 minutes that would meet the criteria for acquired premature ejaculation, meaning a change in latency time that occurred later in life after sexual debut. So again, just reiterating here again, latency time being short, lack of sense of control, that the patient really doesn't feel like they can control or prevent ejaculation from occurring. And then lastly, bother, because if the patient doesn't really care, they don't mind ejaculating quickly, and their partner doesn't care either, in the end, there's not really a there. There's no problem to fix. So I'll hand it over to my colleague, Dr. Althoff now, and let him speak a little bit about the mental health side of things.
Good. Thank you, Alan. And thank you for allowing me to participate in this meeting. So I tend to think I've worked hand in hand with urology for 30 years, being in the Department of Urology and Psychiatry at Case Western. So I think it's important when you have a person that qualifies with premature ejaculation to consider having him referred to a mental health professional, mainly because of the degree of distress that he's experiencing, the degree of distress the partner is experiencing, the fact that we have some behavioral interventions that could help, and also it might benefit the relationship. Can I have the next slide, Alan? So I thought you might find these theories interesting. The first has to do with in relationships, especially in acquired premature ejaculation, we see many men, when they get into interpersonal difficulties with their partner, they develop premature ejaculation. For instance, many years ago, I saw a guy who was dating a vice president CEO, and he was a law officer. And he said, well, she's really a high power and all these things, and it's a little difficult for me to be with her. When asked if he ever dated somebody who he felt was high power, he said, yup. And he said, funny that you ask, I also developed premature ejaculation with her. The second thing to think about is conditioned patterns. An example of that would be if the man's female partner has genital pain and they're having intercourse, that the woman will probably wince or in a way be pleased that he ejaculates quickly. And what he does is he learns to ejaculate quickly because he cares about his partner and doesn't want to hurt her. We call this sort of the, it takes two to tango. We look at both the man and the partner. And there are several studies that will point out how women with genital pain will have men who have rapid ejaculation. The last two are sort of chestnuts from the psychoanalytic era, which refer to the man's hostility to women. That is, by ejaculating quickly, he deprives her of pleasure. And then there are those that are more in the sort of obsessional spectrum who actually fear the vagina. They don't like the wetness and warmth of the vagina, and they sort of are afraid of a sexual organ that's internal rather than external. But the real important thing for you to remember here is that performance anxiety, the man's fear this is going to happen again, I'm a crummy lover, all the things that are associated with the mental events maintains the PE and makes it worse. Can I have the next slide? So to be more explicit, PE is associated with diminished sexual satisfaction for the patient and partner. It negatively impacts on the man's self-esteem, sexual confidence, and intimacy. Most men, all as Alan said, are significantly bothered by the dysfunction, and the partners of PE men are significantly bothered as well. It has detrimental effects on the relationships. I'll show you that on the next slide. And what's really important here to keep in mind is that PE interferes with single men beginning new relationships. Their PE has often interfered with the establishment of a new relationship. They're embarrassed, especially if the woman is in his circle of friends and so on. Next slide. So there's PE causes a significant strain on the relationship. The woman tends to distrust him. She loses hope that sex will ever improve. And often the man is perceived as selfish because he's not doing anything to make things better. Obviously, they're both dissatisfied with the sexual relationship. But when you ask about this, you say to the man, what does your partner think? He may say, oh, she's never raised this issue because she fears hurting his feelings, or she doesn't know how to discuss this, or she may think this is a normal condition. But many of them think, nonetheless, there's no solution, and that leads to the hopelessness. Next, please. So just 2 quick studies here to show you how women are affected. So almost 1,500 women from 3 countries participated in the web survey that Andrea Burrow and Francois Giuliano did, and they found 3 important things. The male's lack of attention to her and focus on his performance. That is, instead of connecting with her while they're making love, he's so worried, I'm gonna come, I'm gonna come, I'm gonna come, that they feel disconnected. And almost half the women reported this. They also reported an upset with the short time between penetration and ejaculation and the man's ejaculatory control. You may find this interesting. Women with fewer sexual problems considered ejaculatory control more important and reported more PE-related distress. And a quarter of the women noted that the man's ejaculatory problems had previously led to relationship breakups. Next slide, please. And again, just to point this out using more quantitative study. So there were 2 groups here in this study. There were women of men without PE and women of men with PE. All the women were administered the female sexual function index. That's the gold standard instrument that's been used on the female desire drugs. So the FSFI scores for partners of men with PE were significantly lower than the scores for partners of the control group. And we use 26.5 as the normal, that is under it, it's functional, over it, it's okay. 78% of the partners of men with PE versus 40% of partners of men with no PE were diagnosed with a sexual dysfunction based on this instrument. Next, please. So, of course, the psychological interventions include psychotherapy, whether it's individual or couples, and it's recommended for acquired, and natural or subjective are really people that don't qualify for the diagnosis. The first line really for lifelong PE, as Alan's going to tell you in a minute, is probably a pharmacotherapy. And psychotherapy is an integration of psychodynamic, behavioral, cognitive, and systems approaches, and it's short term, that is several months. We try to harness the power of the mind to teach the man a set of skills. We also engage in combination medical and psychological therapy, where with lifelong and acquired subtypes, they may get pharmacotherapy and usually simultaneously some psychological intervention. For men who don't qualify, we try to understand more about it and offer reassurance and education. Next, please. So these are really the behavioral treatments rather than psychological treatments. That is, Masters and Johnson introduced us to the squeeze technique. They also spoke to us, these were in the early and late 70s, about sensate focus. I'm going to show you on the next slide or two what you could do in terms of giving men and their partners the stop-start technique. And cognitive behavioral approaches are also useful to deal with all the junk and distractions and performance anxiety. For some men, pelvic floor exercises are useful, and often integrating a number of these are the best ways to go. Next, please. So these are going to be the instructions for stop-start. And the reason I'm doing this is I think any of you could add this to a pharmacotherapy if you wanted to. Now, the reason this is important is stop-start exercises are based on the premise that the man chooses not to be aware of his sexual excitement. He fears that if I focus on how excited I am, I'll start to ejaculate even more rapidly. Unfortunately, not knowing where you are on the level of sexual excitement causes rapid ejaculation. So I say to men, imagine your sexual excitement on a 0 to 10 scale, with 9 being the point of ejaculatory inevitability. I ask him to masturbate to a mid-range of sexual excitement, like a 6, and then stop. Allow his excitement to dwindle to a 3. When it dwindles to a 3, resume masturbating to a 6, stop again. Resume masturbating and then ejaculate. And he needs to do this several times weekly for at least 2 to 3 weeks. And he'll tell you, I'm beginning to get a sense of having some awareness of my excitement. Next, please. Once he masters this, I ask if the partner would be willing to participate in these exercises. Not every partner will want to, but for those that are willing to, I have her manually or orally stimulate the man to a mid-range of excitement. Again, a 6. When he's at a 6, he asks her to stop. She then resumes stimulating him when his excitement is dwindled to a 3, and then stops at 6. Then do it one more time and ejaculate. What's important here, so the partner doesn't feel used, is to ask her what she desires and what she would like to receive from the male partner, and his instructions are to provide this to her. Again, this should be done several times a week over a period of 2 or 3 weeks. The next level is penetration of the vagina, but both partners lie still. So the man learns to tolerate the wetness, warmth, and excitement of penetration. They do this for at least 2 minutes. If it's too exciting, that is more than a 6, the man withdraws. And the last level is that the man begins gentle thrusting, but stops when he reaches that 6 again. And you continue this stopping and starting several times, and then he can ejaculate. Men who do and can make it through all this do relatively well. I'll show you a study coming up next, I think. Alan, can you give me the up? So this was had 2 arms of the study, a waiting list and a behavioral, where they did stop-start. The baselines were 57 and 63 seconds respectively. At the end of treatment, the men had a IELT, ejaculatory latency, of 472, almost 5-fold or longer increase, and they maintained this at a follow-up. You can see the waiting list didn't get any better. And I think that's my last slide here, Al.
Thanks, Dan. So appreciate that a lot. Again, from the APP perspective and what we do in urology offices, obviously you will eventually refer some of these patients to see someone like Dr. Altoff, but we can start the evaluation first off with the inquiry, and that's a whole separate session on itself, how to talk to patients about sex. I'll assume you already have a good grasp of that because you're here though. Physical examination is not deemed essential. It can be reassuring, and patients generally prefer it if they're in person, but especially in COVID world, the necessity of that exam is pretty limited because there aren't a whole lot of physical exam findings that change management. We also don't typically mandate necessity of stopwatch testing. It just asks the man, how long do you think you last? It's not entirely accurate. But if you're not doing a clinical study, I think a thumbnail sketch of how long ejaculation, the interval between penetration and ejaculation, is all you need to know as an estimate is fine. Don't bother them with stopwatches. So the diagnosis can be assisted by the use of a number of validated instruments, which are highlighted right here. These are all Likert-style multi-component surveys, which have various strengths and advantages. You see 3 of them here. I think that they're all potentially useful. I would say that the PEDT is used fairly extensively in research because it does have a ostensible cut points for the diagnosis. Now, with any kind of scale, I think you do want to be cautious. These scales can be good icebreakers. They can help start the conversation. They can give you a sense of response to therapy, but you can't rely on them to make a diagnosis for you in clinical practice. You really should rely on asking the patient those 3 fundamental questions: latency time, control, bother, to really understand, do they have a clinical problem or not? And don't rely so much on what the scale says if you want to make the actual diagnosis, but do use these to help facilitate conversations and track response to therapy. I think it's where their real strength lies. We do not routinely recommend any adjunct laboratory testing for patients with lifelong PE for the simple reason there aren't any that are thought to be actionable. You know, there was some interest about 10 years ago in whether there were genetic polymorphisms that might alter serotonin metabolism. Certainly, this is a logical hypothesis, and there are some data suggesting it might be relevant. But the relevance of any one serotonin transporter polymorphism was so marginal and so heterogeneous in its effects that it wasn't deemed to be a clinically useful set of tests, at least not as it stands right now. Because acquired PE is sometimes associated with other conditions such as erectile dysfunction or prostatitis or prostate infections or thyroid abnormalities, we will sometimes recommend using additional adjunctive testing for men with acquired PE, but that is again at the discretion of the provider and based in large part on what the symptoms are and whether or not additional testing makes sense. So first line pharmacotherapy, once again, not FDA approved, but well evidence-based, would be daily dose SSRIs, on-demand use of clomipramine, the tricyclic antidepressant, or duloxetine, a short-acting SSRI available in other countries, but not the United States, and topical anesthetics, most commonly a prilocaine cream or eutetic spray that can be applied to the penis. These are all considered first line. There's not a rank ordering of these, and it's just a matter of personal preference, which, if any of these, the patient would go to first when considering pharmacotherapy for premature ejaculation. SSRIs are kind of the mainstay of medical management. And again, of the SSRIs available, these are the ones and the dosages that have been reported as efficacious. An on-demand regimen has been reported in a number of limited studies. And the advantage of this is that it doesn't mean a daily dose pill. It does have a somewhat lower efficacy. And it is reliant to some extent on a loading dose, you know, building up a certain level of the drug in the system, and then having sex on at least some regular basis, at least twice a week that you're taking the pill to maintain steady state levels of the SSRI in the system, and also to avoid the potential for withdrawal from the drug, which is a separate consideration, but something that's worth thinking about. SSRIs all have evidence for efficacy. As I mentioned, the one that has the most robust efficacy is paroxetine. In urology, we don't prescribe a lot of SSRI, so unless you make PE part of your practice, you're probably not super familiar with this. It's a very safe class of drugs. It has some of the general side effects that many drugs have, such as fatigue, some nausea, etc. It should be used in caution in patients with bipolar because it could precipitate a manic episode. It should be used with caution in younger men with depression because there has been reports of men getting SSRIs and then having suicidal ideation because it lifts them out of the depression, but it lifts them only so far that they suddenly have motivation to do things that are potentially self-harmful. So be very careful and caution patients about this ahead of time, that it can change mood. It also should be used with caution if the patient is already using other drugs from this class or certain pain medicines or tricyclic antidepressants. You need to be aware of the potential for serotonin syndrome, which is rare, thankfully, especially for monotherapy with an SSRI. But it includes muscle fasciculations, agitation, hyperthermia. Those are the early warning signs and can progress to seizures. So this sounds very scary. Obviously, I don't want to scare you off from using SSRIs. These things are quite rare, but there are things you have to be aware of and have to counsel patients about if they're thinking about the SSRI type option for their premature ejaculation. Topical anesthetics have the advantage they avoid a lot of those other potentially scary, if rare, side effects. And these are just basically applied to the penis, left in situ for on the order of 5 to 10 minutes. The amount applied and the duration of application can be modified. So I tell most patients start with a 5-minute application, then wash it off very thoroughly, and then have intercourse with your partner and see how it goes. If the penis becomes too numb, you can always back down on the dose. If it becomes not numb enough, you can increase the dose or leave it on for longer. And the patient can kind of self-titrate. The downside of these is they're a little bit messier, they're a little bit less reliable, it's a bit more of a production than just popping a pill and hoping for good results. But it does avoid those central nervous system effects, and many people do like that aspect. And there are ways this can be administered as a spray, for instance, that can be a little bit easier to use than, say, applying an ointment to the penis and then letting it sit there for a period of time. Beyond the first line therapies, we do have a couple of options. Second line, on-demand tramadol, the mu agonist analog of opioids, and also alpha blockers, which I'm not going to talk a lot about alpha blockers because you're all familiar with them. The data supporting their use is quite minimal, but we included this statement based in large part on deference to one of our colleagues who's a world expert on this topic, and the fact that these are very benign drugs. We will sometimes talk about them, but I'm honestly not very convinced they do much good at all. Tramadol does have an evidence base, and it could be either a central or a peripheral mechanism of action. And you can see here from this meta-analysis that there was a consistent effect that tramadol did increase ejaculation latency times. The concern I have, and obviously I think it's probably self-evident to most of you, is that there's potential for addiction here. And given that we are still in the throes of an opioid crisis, I'll be honest with you that I think maybe once have I prescribed this for PE after very thorough counseling. Because it is something that you have to be very cautious of, administering this drug. So many times when I talk to people about it, they don't really go for it. I mean, people are savvy enough about opioids now. They really don't want to take them if they don't have to. And I think tramadol might be a bit of overkill, but I present it here for completeness' sake in the sense that this is a drug that has been shown to have some efficacy for this condition. A lot of men, and actually I saw one of these just by total coincidence, a patient I saw earlier today came in with this very question. Is circumcision associated? Well, the data seem to suggest there is no intrinsic relationship between circumcision status and premature ejaculation. This is based largely on this study from 2018, which was a meta-analysis combining over 21,000 men who were circumcised versus not. And there was no discernible consistent trend in terms of ejaculation latency between men who were circumcised versus not. Now, having said that, you may encounter patients who have severe phimosis or have some other genital condition of their foreskin that leads to increased hypersensitivity. And there are probably cases where circumcision status, either circumcised or being uncircumcised, may be contributory. And I wouldn't necessarily recommend circumcision as a routine therapy. But if there are other symptoms, such as balanitis, discharge, difficulty with urination, hypersensitivity that is, potentially involved with the foreskin, circumcision could conceivably yield some benefit for those patients who are properly selected and counseled. There are a number of surgical approaches beyond circumcision. So just looking at a patient who comes in saying, I have PE, what can you do for me? I don't like these pills or these shots or whatever else you have to offer. These approaches have been primarily promulgated outside of the United States in Egypt, Republic of Korea, and the People's Republic of China. The most commonly utilized things you'll read about would be selective dorsal neurectomy, primarily in the context of men who are uncircumcised and present for circumcision with concomitant transection of nerves that go to the head of the penis to make it less numb, so kind of a permanent nerve block like the topical anesthetics. Hyaluronic acid injection. Hyaluronic acid is an orthopedic drug that's used for joint filler as kind of a lubricant and a bulking agent. It can be administered in the glans penis by injection, and it has a similar effect, once again, of, to some extent, increasing gland size, which some men like, and can also potentially increase or decrease sensitivity. That's how it's thought to work, and it has a body of evidence supporting its use. And then in the context of men who have concomitant pelvic pain syndromes, percutaneous nerve ablation has been applied, and that's something that's very select cases and select case reports. So I won't go into those in detail. Those are all considered experimental, but they do exist and are things that may be an option in the future. The previous guidance from AUA about PE with comorbid ED was that you should always treat ED first because it was thought to be more disabling. And I'll be honest that my personal opinion is that in most cases, if a man has both, you may realize more benefit and be working more within the lines of standard medical therapy if you treat ED, because we have all kinds of different pharmacotherapy for ED that is FDA approved and potentially covered. And truthfully, in many cases, for the acquired PE, the fundamental issue may be, in fact, ED, and the man says, boy, I might lose my erection real soon. I better speed up and have sex real fast before it goes away. You can give that man more confidence and more ability to approach sex in a leisurely, pleasant fashion, you might find that the PE goes away if he gets simply a better erection, a more durable erection. That is not obligatory. And if you encounter a man where it seems that really the PE is the fundamental thing, that he ejaculates super fast, lifelong PE, and if he just didn't have that problem, he'd be able to get an erection more reliably, you could certainly focus on treating the PE first, if that's thought to be more appropriate in your own clinical judgment. So let's shift gears entirely to go to the opposite extreme of the spectrum here. So we've been talking a lot about premature ejaculation. Let's talk about delayed ejaculation and the most extreme variant of that, which is anorgasmia. These are the definitions. You'll notice some similarities here, that they again rely on the same fundamental criteria of consistent difficulty achieving ejaculation, lack of ability, so lack of control, once again, excessive latency, and a bother from it, you know, a sensation that, boy, this isn't the way I wish it was. And this applies to both lifelong, meaning a man who has never been able to reliably reach sexual climax during intercourse with a partner, and acquired DE, which is someone who previously was able to ejaculate during penetrative sex with a partner, but is no longer able to do so. I would say the lifelong population tends to be younger men, many of whom also have other psychological morbidities, but not always the case. The acquired delayed ejaculation is oftentimes your post-prostatectomy patients or older men with neuropathies or other neurologic conditions that probably contribute to the syndrome by decreased tactile sensitivity. So some fundamentals here, once again, your history and physical is critical. We do routinely recommend checking a serum testosterone and any other labs seem appropriate based on the patient's clinical context. I think it's important to assess the psychosocial milieu, and Stan will speak more to this in a moment. It's also important, as I mentioned earlier, there are two things here. There's orgasm, there's ejaculation. And most men don't distinguish, and most of the literature on this topic doesn't really distinguish it either. So when you meet these men, it's important to ask them. And this nice little table from Chris McMahon from Australia really lays out a nice algorithm here. But the first question is, well, do you have a climax? Do you feel excitement? Do you feel a rush? Do you feel an orgasm? Because that's really something that you need to know up front is the problem that they don't reach a climax at all. And hence there's an absence of both orgasm and ejaculation. Or do they reach an orgasm at least some of the time, but nothing comes out? They don't ejaculate. And if that's the circumstance, then you have to say, okay, well, is it a problem with the mechanics in the pelvis, or is it a problem with the central nervous system integration? And again, a lot of this diagnostic reasoning and planning for next steps is going to be driven by this important distinction. So failure of emission, inhibited excitement, psychological disturbances, which again, I'll leave it to Stan to speak to those with much more authority than I ever could. But establishing this up front is really important. We do recommend that adjunct testing can be useful. So testosterone is a routine part of this. You could check for other evidences of neuropathies with biothesiometry, such as simple sensory testing. This can be done with a specially designed vibrator, like a biothesiometer. You can also do it simply, you know, with a Q-tip and a wooden tip applicator, and just, you know, test for sensitivity along the course of the penis or on other sites to see if there's evidence of decreased penile sensitivity. And that's something you can do without any real fancy tools. You can just get a sense of, is the sensation intact or not. I will hand it back to Stan here to talk a little bit about the mental health evaluation of DE patients.
Right, thank you, Alan. So again, the idea of the referral to the mental health is to perhaps give them some behavioral tasks they can do, or to deal with the psychological things that may be inhibiting ejaculation. Next slide, please. So I want to give you the top 3 psychological theories behind this. The first is insufficient stimulation. That is, as men age, there are theories that say that it requires more stimulation to achieve that threshold over which he then can ejaculate. So the first one is he receiving sufficient stimulation? The second theory has to do with idiosyncratic masturbation. That was something coined by Michael Perlman. So the basic idea here is that the man has learned to masturbate in a way that doesn't mimic intercourse. For instance, lying on his stomach on the mattress and pushing the penis against it. But that doesn't really translate into the same kinds of stimulation that he would receive with penetration. many of these men, Michael Perlman reports, also show a disparity between their fantasy life being more into BDSM and so on, and reality with their partner. The third one is a more psychoanalytic idea, which is the outgrowth of psychic conflict. So I see several times a year a man who tells me that he's in a new relationship, and he's in this new relationship and can't ejaculate. And the first thought that comes to me as he starts telling me about this new relationship is that his penis is smarter than he is. It's actually giving him the idea that there's something wrong here and he should attend to it. But there are many ways. There could be fear of impregnating the female, hostility toward the partner, guilt from a religious upbringing, and so on. And it's your job as best you can to try to ferret out which of these or which combination of these is leading to it, because that will help you define the treatment. Next, please. So treatment is based upon your judgment as to whether the symptom is due to inhibition, that is the psychological, like guilt or religious upbringing, lack of excitement, like he's no longer able to achieve that, go over that threshold for excitement, the atypical masturbation style, or the last one, psychological conflict. I think that's it for me here, Ellen.
Great, thanks, Dan. So the mental health side is something that's always part of it. From the medical side, what we can apply is, first off, take stock of the medications the patient's using. So very commonly, you will find that patients with acquired DE have started an SSRI or other psychological medicine. And truthfully, there's so many of them now that I haven't kept track of, that there's many that I'm not really familiar with. But generally, my alarm bells go off when I see anything that someone is taking that has as an antidepressant or anti-anxiety medication as a primary indication. Obviously, another major one would be anti-androgens. So someone who's on hormone ablation therapy for prostate cancer, being the most common cause of that, it's very common that those patients will have a marked change in many aspects of sexual life, including ability to climax. Those being the big categories. Obviously, if there's some other association that, I started this pill and all of a sudden I had a lot of trouble, potential things like gabapentin or tricyclics, the drugs that we talked about that are potentially useful in the case of PE may be very detrimental in the case of DE. And in that case, if it's possible, it's advisable in the consultation with their prescribing doctor or provider to have them stop that medicine if it's at all possible. There was evidence, interestingly, another colleague of ours who was on the panel, Darius Paduch, was part of a study where they looked at testosterone supplementation for mitigation of ejaculation issues. And the study that was done by Darius was actually negative, meaning that giving a man testosterone and hoping for improvement in delayed ejaculation did not pan out. However, in a subset exploratory analysis, so not the best level of evidence we're talking about here, and it wasn't even peer reviewed or published yet, so I think it's something that I approach with a certain amount of skepticism still. But in a subset analysis of that study, looking at men with low serum testosterone and delayed ejaculation who achieved therapeutic levels of testosterone, meaning greater than 400 nanograms per deciliter, there was a clinically relevant benefit for those men in terms of restoration of ability to achieve climax. So we're waiting on more data and better data on this. And that's why this has the level of an expert opinion rather than an evidence-based recommendation. But there is evidence to suggest that in the right man with low T and DE, supplementation could be of some value. Wait and see on more data on that. Hopefully we'll have more in the near future. So there is not at this time a medical therapy, oral pharmacotherapy that has been shown reliably to achieve improvements in delayed ejaculation. And I would say the same thing would apply to any kind of invasive therapy. So this is even less evidence-based than anything that we have for PE. And I would not generally recommend any kind of invasive surgical therapy with the intention of improving ability to reach climax. Outside of the context of a clinical trial, at least, I would say that that would not be appropriate. Having said all of that, I will report out to you there are a number of interventions that have been proposed from the biomedical side. One of them being penile vibratory stimulation. This is a study from Chris Nelson up at Memorial Sloan Kettering, looking at the application of a vibrator to the frenulum of the penis for a period of 3 months on a regular basis. Now, if you look at this, you'll see the endpoints are relatively squishy. Some restoration of orgasm, some encounters resulted in orgasm. Ultimately, while it's not super compelling in terms of, these are really robust data points, I will say that applying a vibrator to the penis is pretty safe. There's not really a lot of downside to applying this. And I think more importantly, what this invokes is not so much even the notion of training up the nerves or conditioning the penis to be more responsive again, which it could very well be that too. But it invokes the idea that changing up what one is doing sexually, to get at what Stan was talking about, insufficient stimulation, changing sexual positions, getting some sex toys, getting lubricants, engaging in fantasy, engaging in role play, anything that intensifies that arousal response is worth exploring within the bounds of what's acceptable to the couple in terms of what they're willing to do to one another. And sometimes people say, I don't want to do that. That doesn't sound like something I want to do as part of my sex life. But giving them license from the medical perspective can have a lot of power, and just opening up the door to say, hey, why don't you explore things that feel good? Get back to having fun with this, rather than making it a fixation on we have to reach climax, otherwise it doesn't count. A lot of couples are under that assumption, unfortunately, that it's about how many climaxes you can get, not about having fun. And I think that winds up being counterproductive, is when people are so fixated on orgasm, they forget that it's supposed to be fun. When it becomes just performance and a task, it really kind of loses the point. So I think this study, to my mind, somewhat emphasizes that from the medical perspective, and it goes along with what Dr. Althoff and many others would say about it too. There are a number of drugs that have been reported, usually in single case reports, so bupropion, buspirone, amantadine, ciprofloxacin. The one that has the largest study is cabergoline, the dopamine agonist that is used primarily to suppress prolactin-producing tumors. This study came out of Baylor University, 131 men with anorgasmia or delayed orgasmic response who were treated with this drug twice weekly. And once again, a very subjective, somewhat squishy endpoint here of improvement, but it was 2/3 of men who have reported that. Now, no placebo arm, no validated instrument used. So take this for what it's worth, very poor evidence, but it's a treatment that is pharmacological for a condition where we don't really have a whole lot of other great options. I've prescribed it a number of times. I've had mixed results, but I've had some patients come back saying it really helped them. So I am personally a believer that this is an option to discuss. It's worth, once again, emphasizing this is off-label use. It can have some annoying side effects. There's also a hypothetical concern that this can induce mitral regurgitation by stimulating dopamine receptors that are present in the mitral valve of the heart. I've never encountered that. I've never heard of it happening at the doses we're talking about here. But because, again, we're in the off-label world, I make it a point to discuss this with patients that, yeah, it theoretically is possible. I don't think it's going to happen. I want you to be informed of this before we sign up. And most men say, yeah, sure, fine. It's okay. We can take this minor risk, but make sure you document that too. So there's more we could obviously say. We could spend hours talking about this, but I know we're all on a schedule, and I do want to leave some time for question and answers if we have any of them. I first off want to say thank you so much, though, for attending late on a Thursday evening when you all could be doing other things. I appreciate that you took the time to spend time with me and Dr. Althoff, and we're happy to take any questions you might have right now.
At this point, there are no open questions in the Q&A. I see one.
Oh, yeah, Patrick already. Oxytocin, yes. So oxytocin, thanks for reminding me on that, Patrick. Oxytocin does have a number of studies that were published on it. So basically, oxytocin is interesting, and it makes a lot of sense because oxytocin is released in large quantities at the moment of sexual climax. It has a lot to do with pelvic floor contractions and labor, as we're all aware. So it has a nice set of physiological principles that underscore it as a potentially useful therapy. In the studies that have been done looking at the intranasal oxytocin, it has not been particularly better than placebo when it's been compared. And my experience with it, prescribing it to patients, I'll sometimes turn to it as a first line thing because it's there and it's not going to hurt anybody. I honestly don't think I've ever had a patient come back to me and tell me that helped. So I'm not personally a fan. I don't, Stan, have you had a different experience with oxytocin or told people about it and had good results?
No, I was involved actually in a study on women where we gave intranasal oxytocin as well. And the results were disappointing, even though theoretically it does make sense.
Yeah. Yeah, I wish it worked better, but I've never seen it help anyone. So I don't really talk to patients about it much anymore, to be honest with you. Tanya asked about dry ejaculation. So that's an interesting question. And it certainly, as I was talking earlier about the significance of ejaculation, even aside from orgasm, to many men, it makes a big difference, and people are oftentimes very distressed by it. So dry ejaculation could be a few different things. It is commonly a side effect of alpha blockers, particularly tamsulosin and sildenafil, less so with alfuzosin. So if a man comes in with dry ejaculation related to alpha blocker therapy, I would say consider alfuzosin as an alternative, because that has a lower incidence, not zero, but lower incidence of dry ejaculation. It can occur in the context of finasteride or 5-ARI use as another potential cause. It is very common, I would say ubiquitous and virtually impossible to treat after transurethral resection of the prostate or holmium laser enucleation of the prostate. So any kind of TUR procedure on the prostate will almost always lead to this. If there are issues of autonomic neuropathy, people will have failure of the bladder neck to close and will have retrograde ejaculation in most cases, or if they've had a retroperitoneal lymph node dissection that disrupts sympathetic nervous tone to the lower urinary tract, they will have dry ejaculation. Again, this means different things. It could mean failure of emission. It could mean retrograde ejaculation. It could mean, and this happens also too, there is a baseline decline as men get older and the strength of the ischio-cavernous and bulbospongiosus muscles that mediate the ejection process. So it's natural that many men say, I don't, come as much as I used to, or I don't have as much come out as I used to, and I don't like that. I'm like, I'm sorry. It's unfortunately kind of the reality that a lot of people go with. And it's sort of something that most people, barring a desire to conceive, it doesn't really make a medical difference, but it does. I acknowledge the fact that it's distressing.
Right. And I think, Alan, that's the main thing, if I could comment, is the meaning of that symptom to the men or to the partner. As you said, there's probably not a lot we can do about it, but one has to deal with what the meaning is. Does it mean I'm getting older? Does it mean I'm not as virile as I was? Does the partner think, oh, it's because you're not attracted to me? And so I think from the mental health perspective, one sort of has to understand and ask about the meanings.
Yeah, thanks for that, Stan. I think you're exactly right. A question about the dosing of clomiphene. I think generally speaking, it's on the 25 milligram dosing, even up to 50 milligrams is sometimes talked about if you read the studies on this, but 25 to 50, I would usually err on the side of starting low, because tricyclics are generally much more difficult to tolerate than SSRIs. So I use those with caution. I have used them before with benefit to patients, but they're not my usual favorite option because they simply cause more side effects. Looks like Omar is here. Hey, Omar, how are you doing? You're asking about ejaculate cups. Was that for me or was that for Stan?
Well, I can take that. There are a number of devices like the Fleshlight or other devices that you can buy.
Oh, those, right. Mm-hmm.
But the issue would be, I think they have limited utility, both in PE or in DE. They help in DE because they may be a way like the vibratory stimulation to help the man reach the threshold. For PE, they have limited utility because it's not exactly like he learns to focus on his sexual excitement, which is the whole key to this. So using the device by itself without the recognition of the purposes, I need to be aware of how excited I am as I'm moving forward with this.
Yeah, thanks for clarifying that, Stan, because I wasn't thinking of Fleshlight. That's the term that comes to my mind when I think of these devices. Stan has more expertise on this, so I'll defer to his judgment on that. I will say that if you're of the Michael Perlman school of thought that says that idiosyncratic masturbation that doesn't feel like a vagina or anus in the case of someone who engages in anal insertive sex, I would venture to say if that's really what's going on and someone wished to condition themselves to respond to something that feels like a vagina or a rectum, Fleshlight does make a good product. And if that was something that was thought to be useful, I might say that would be good for the training, the training of someone who has the idiosyncratic masturbation style, if you believe in that. But otherwise, I would say, in terms of what Stan's saying for PE, it doesn't sound like it'd be something terribly useful. Is that a fair assessment, Stan?
It
what
is.
You were saying?
Yep,
okay.
It is.
Omer, you also asked about sublingual versus oral DE. I'll be honest with you, I don't have a whole lot of thoughts on that. I haven't really had experience prescribing the sublingual or oral DE. My sense being that, the intranasal is probably the most direct way to get it where you want it to be ASAP. So I'm not overly optimistic. Now, you can type in the chat there, Omer. I mean, I respect your judgment on this. If you've had experience with it and you've had good success with it, I would certainly say, hey, maybe it's worth a try after all. But I have not personally used a lot of oxytocin outside of the nasal spray option. Stan, do you have thoughts on that?
No, the drug that, again, of course, I can't prescribe as a psychologist, but the drug that I found the most useful, again, 50 to 6% of the time, is the cabergoline, that men do relatively well with that.
Yeah, that's been my experience. It's the only drug that I've prescribed for DE that actually has at least sometimes made a difference. So that's kind of become my go-to. And truthfully, a lot of the time after we try that, a lot of guys are like, that's not bother. And I've gone beyond cabergoline with some people, but I've not yet had success with it. Any other thoughts or questions?
There are two other questions in the Q&A, one from Eric Larson. Any thoughts on the use of constriction bands / devices for either PE or DE?
I have not used them. I would say I use those more often for ED, for venous leak ED, and I wouldn't necessarily apply them in this context. I'm not familiar with data saying they would be useful, but again, your mileage may vary.
Right. Because I think they're not going to, again, get the man to attend to his level of stimulation, nor for the man with delayed ejaculation, help increase his level of stimulation.
Yeah. And Mark asked a good question, Mark Goldberg, a question about lifelong PE. And this is oftentimes what we see. And Stan, you've encountered these guys too, where they say, I masturbate just fine, but when I'm with a partner and I'm trying to climax inside my partner's vagina or rectum, I can't do it. And I don't reach their climax that way. And the implication is that this is probably largely psychological. And I would always invoke someone like Stan if I'm lucky enough to live close to him, or someone like him if I don't. I would definitely include sex therapy as part of that. I wouldn't preclude or deny a man like that the option of pharmacotherapy, but I would definitely say that behavioral and psychological interventions are going to be primary.
So the key takeaway here would be that variability is the hallmark of a psychological issue. So if he's masturbating, and of course, he may be masturbating to pornography, be by himself, so there's no pressure to perform. The fact is that you can see the difference between the masturbation and the performance with the partner as the psychological part. And you'll have to help him understand or work through or resolve what the performance issues are that cause him to ejaculate more quickly with the partner.
Yeah. I mean, masturbation is so low stress. There's no performance aspect at all. So I think that does make a difference. And it implies that the psychology and the challenge of sex with a partner, I mean, especially for early and sexual encounters, it's stressful. So it's not atypical. Thanks for the great questions, everybody. I appreciate your participation. And obviously, we got one more. So Jasmine's asking, I guess maybe this is another one for you, Stan. I think you gave some nice armchair, back of the envelope sex therapy tips that we can apply in biomedical settings. Any other suggestions on the conversation?
Well, I
have a thought too, but I want you to go first.
Okay, thank you. You gave the idea that permission is often the very first step that the physician can give. Have you tried something different, novel, atypical to increase stimulation when we're talking about delayed ejaculation? So that would be one thing. and the idea of moving through the therapies in a more intensive way. So you may not necessarily start off with, referral to a mental health person. It may be helpful, but it may be number 2 or number 3 when the person comes back and reports there isn't a significant change.
My experience, having a very similar experience, Jasmine, a lot of patients are resistant, especially the ED patients. The young ED patients will usually say, no, not at all, impossible. There's nothing possibly psychological. It can't possibly be true that there's anything psychological whatsoever, full stop, end of story, which is ridiculous, obviously. So my conversation with patients when I go through the list of ED or PE or anything is that there has never been a sexual problem in a human being anywhere in the universe that has probably not had some psychological overlay, either as the primary cause or as a secondary thing that results from the problem itself. So I, number one, say it's ubiquitous. You can't deny that. And most people say, okay, I get that. And I then go to the world of saying that when you are anxious or stressed or nervous or having performance anxiety, your body is going to react biologically in a stereotyped way by releasing adrenaline. The sympathetic nervous system tone will increase. That has all sorts of negative impacts on erections in particular, but potentially everything else regarding ejaculation and climax. So what I do there is I sort of say, I'm not saying you're making it up or it's in your head. I'm saying that your body's stereotyped unstoppable response to stress is to invoke a physical process. So if you can find a way to psychologically overcome that stress, you can mitigate this physical change in your body. So I bring it back to biology. I don't say, oh, you're crazy, it's in your head, you're making it up. It's more like, yeah, what's in your head matters a lot for what happens in your body and your penis.
So Alan, if I could add, I try to talk to these men and use the word distraction. When they start to say, oh, I can't maintain my erection, I'll ask what they're thinking. And they'll say, oh, I'm worried I'll disappoint my partner. Here I go again. I'm going to feel embarrassed, ashamed. She won't want to continue to date me. So I try to say to them, there's nothing erotic about those thoughts. And you need some degree of eroticism, like knowing what, looking at her, looking at your partner and so on. So the degree of eroticism is pretty important. And I try to get them to diminish the negative, distracting thoughts and focus more on the sexual excitement.
Yeah. Eric's probably last question for us about sex tech devices. We talked a little bit about fleshlights and the different cups, and obviously there's all sorts of doodads and trinkets and different things. Again, I don't have any particular ones that I turn to. I'm happy to hear of any that Stan does. I generally, though, start with just permission. Hey, why don't you go to the store and see what's there and explore, and you just see what works for you ethically, morally, inclination wise. Pick out something you like, and you might discover something really fun. But I don't have any specific things I tell them they should look for. Stan, do you have thoughts on that or things that you've had good luck with?
I certainly say to them, the men with DE, that there's little downside to the purchase of a vibrator, and it might feel good and be fun. I think if we can end on this idea is men become obsessed with the performance of being sexual, and they're not focused as much on pleasure, either receiving pleasure or giving pleasure. So I try to get them out of the mindset of this is not a competition, this is not a performance, this is about lovemaking, this is about having fun, eroticism, and so on. So I try to move them out of the performance demands that they place on themselves. And that's often helpful. Devices specifically, other than a vibrator, I don't really recommend too many. I'm like you, why don't you take a look at the store and see what might turn you on? I may recommend for some men with delayed ejaculation, some erotic literature. But again, the idea there is to increase the level of stimulation if I'm thinking you're not getting enough.
Yeah, I think I've learned that from you, Stan. It's like focus it on fun. And I think so many men fall into the trap of performance and make it about how great I am versus just having fun with their partners. But I think that's another thing to be very cognizant in all of sex medicine, I think.
Right.
Thanks everyone for sticking with us. I got to go cook dinner for the family, so I got to drop off myself. But thanks again for the questions. Thanks especially to SMSNA and Stan. Thanks for being here and doing the session with us.
Thank you for attending, and thank you for inviting me. Good night,
all right,
everyone.
Be well, everyone. Have a good evening. Bye now.